Shireen is brilliant, good looking, and an excellent friend. She has worked on the money side of medicine and healthcare for many, many years. So this is our attempt to simplify a complicated subject, which could really be a year-long seminar. We will do this in one fell swoop. Shireen is going to present the first half, and then I will chip in for the second half.
Okay, thank you. Thank you, Dr. Schultz. I appreciate it. Hello, everyone. As Dr. Schultz mentioned, we went to healthcare MBA school together. I also have a master's in healthcare law. I currently work for a population healthcare management company that really focuses on wellness and disease prevention of our senior population. And I run their compliance and privacy departments. I also have extensive background in compliance for technology, in operations, as well as in revenue cycle. So, which is why Dr. Schultz asked me to participate, and I appreciate the opportunity to co-present with him and appreciate your time today. So let's get started. So as Dr. Schultz mentioned, we're going to be talking about managed care. And as you can see this maze on the screen, it really is, trying to navigate and figure out what the right things are when it comes to managed care and what that means. It is a maze, and we're hopefully going to clear a little bit of that up. But other than that, we know that associated patient advocates are available to also assist patients in this navigation of the managed care system. So we're going to touch base on what is managed care. We'll talk about all the acronyms that are along with managed care: PPO, HMO, EPO, points of service, which is the POS. So we'll talk a little bit about that alphabet soup. We'll talk about selecting a plan, how that managed care money and the finance works, as well as, Dr. Schultz will cover, getting the best results from your plan and your provider. So when we talk about managed care and what type of care that is, managed care is really focused on reducing costs and providing high quality care. So many of the features in managed care, along with the different types of insurances, which we're going to cover in a moment, some of those features are, provider networks. So provider networks are where providers have contracted with the health plan to see those health plan patients. So there are certain networks that you have to be a part of. And if you sign up for insurance with a health plan, then depending on what type of plan that is, there is more than likely a provider network that you have to go and see, just those providers that are based on that particular plan you've purchased. Some of the plans also require that you have a gatekeeper, a primary care physician who manages your health. That could include referrals to specialists if they're needed, obtaining prior authorizations for certain tests or services that are required, as well as along with that, also there are prescription drug tiers that are involved in a managed care type of network and plan. And really, managed care is really here in the United States. Managed care has not grown past the U.S. into any of the other countries. It really is a function of within the U.S. So we'll go into a little bit more depth. So when we talk about the benefits for in a managed care plan, it's the coverage that health insurance company provides. So certain medical goods and services that they'll provide, depending on what plan you select, those are considered the benefits of that particular plan. Now, there are two different types of benefit plans. There's a defined benefit plan as well as a defined contribution benefit plan. So defined benefit plan tells you, what's covered by that health plan. So it'll give you a list of services and goods that are going to be covered. And under what circumstances will that coverage actually apply? Will you be eligible for that particular coverage? So there are a lot of details that go along with that. And it's very important for you to be aware of the information that health plan provides you so that you know exactly what is covered and how that can get covered, or the circumstances of how you can get approved to have that coverage. So with the defined benefit plan, medical services and goods are defined regardless of the cost of that service that's provided. So for this example here is, if you get into under a defined benefit plan, if you are admitted to the hospital, that health plan will cover that hospitalization, regardless of the cost of that hospitalization. There are certain requirements that have to be met, correct? There are, medical necessity requirements, so it has to be medically necessary for you to be admitted to the hospital. There may be prior authorization requirements, so your primary care physician or whichever physician is going to admit you to the hospital has to get it approved with the insurance company if it's a planned admit. So those are some of the areas within a defined benefit plan. And the difference with a defined contribution benefit plan means it's a fixed amount that health plan is going to pay for that particular benefit. So in this example, we look at inpatient hospitalizations. The coverage for the inpatient hospitalization under a defined contribution plan could be, for example, a total of $500 that the health plan will pay the hospital, regardless of the actual cost that it will incur to provide the services to the patient. So the remaining dollars after that $500 that health plan pays may go towards the patient responsibility amount. So the patient may then have an amount that they would have to pay after that $500 is paid. So it's very important to know the different benefits that are applied depending on what managed care plan that you choose. It's also important to realize that the benefits are really subject to the state mandates and some federal laws like the Affordable Care Act. Really, each of the states are the ones who define what coverage health insurance companies are required to provide to its citizens. So the states really, when it comes to managed care, have the primary responsibility to regulate that insurance. Now, just keep in mind, state mandates only apply to the plans that are issued by those health plans. So for example, HMO and PPO type plans. But if there is a self-funded or self-insured plan that's sponsored by employers, this is not mandated and managed by the state. Those self-funded plans are directly managed by those employers. So a health maintenance organization, or an HMO, with an HMO, there are usually limits to the coverage of care from different doctors and who, depending on who has contracted with that HMO. So one of the things that you always have to make sure of is you want to make sure if you are looking at an HMO, you want to look at the list of providers that are in that provider network for that particular HMO and make sure that the providers that you normally see or that you want to see are in that list of providers in that network. Because typically, under an HMO, they do not cover what we call out of network, unless it's an emergency or dialysis treatment. But out of network means that you're seeing a provider, whether it's a internal medicine provider or another type of specialist, who is not contracted with that insurance. So that would be an out of network provider. And typically in an HMO, out-of-network care is not covered. Again, unless it's an emergency or some type of dialysis treatment that you're going to be receiving. So it's very important to make sure that under an HMO, you know exactly which providers are listed and that you've selected somebody to be seen. Now, also, it may also require that when you select that HMO plan, especially if it's through an employer group or some other mechanism, make sure that you know whether or not that HMO plan requires you to actually live and or work within that service area for you to be eligible to be covered. So sometimes, if you select an HMO plan and let's say that HMO plan is in California, but maybe you have gone and, you're temporarily working in Nevada or Utah, because then those services would be out of network. That may not be covered. So those services, even though you're still employed and working for the company that you got the insurance coverage from, if you go out of network, those services may not be covered. So it's important to know whether or not you have to actually be within that coverage area or that service area to be eligible. And HMOs, definitely do provide integrated care, and they really do focus on, prevention and wellness, because they want to make sure that, the patients are not getting admitted to the hospital or not having emergency room stays. Those are very important as part of how the HMOs kind of operate. So in contrast with a PPO, a preferred provider organization, this is also a type of managed care. This network or the PPO itself, along with the HMO, have primary care physicians, have specialists, have different hospitals and other professional services, home health or DME, durable medical equipment, that is covered under the PPO type plan. Now, in contrast to the HMO, the PPO typically has what we call a little broader network. They usually have more selection of primary care physicians or more selection of specialists that you can see. Whereas the HMO, the Health Maintenance Organization, typically have smaller panels of providers that are listed under there that are contracted with them. So that's one of the things, even though they're the same types of providers, there may be more accessible under the PPO. So that's a consideration when you're selecting a plan. The PPO providers do contract with the insurance companies. They contract for what types of services they're going to be rendering to the patients, and that they're going to be covered by that particular plan. And they negotiate the fees that they're going to receive from that PPO plan from the health insurance company as well. So they will agree upon a rate, which is typically lower than what they usually charge, but which would be typically higher in a PPO plan than if it was in an HMO plan. So some of the features with an HMO, the patient, you have to get access to selected providers within the network. So it's very important for you to stay within the network. Otherwise, services may not be covered. The HMO requires you to have a primary care physician assigned. And that primary care physician, as I mentioned before, is really your gatekeeper. They manage your health to ensure that you're going to the correct specialist, that you are getting the types of services that you need, whether it's diagnostic imaging or laboratory services. So they will manage your referrals and your prior authorizations. And typically, you have to, typically you have a smaller premium and smaller copay amounts or smaller out-of-pocket when you are seeing an in-network provider under an HMO. With a PPO, patients do have the flexibility to choose the doctor they want to see, okay? It is a preferred provider. It is also a provider who is in-network. But where the difference lays there is that in a PPO, they have both in-network providers as well as potentially out-of-network may be covered. So where in the HMO, if you go out-of-network, there are no benefits typically allowed when you go out-of-network on an HMO. But in contrast, the PPO does allow and have some out-of-network benefits. Also, this will be definitely, if you see somebody out-of-network in a PPO, plan, it will be more expensive than if you see somebody that's in network. With a PPO, you can also typically self-refer to a specialist. As I mentioned before, there are larger networks of providers that are available to be seen. But the difference then again is you will have a higher out-of-pocket that you have to pay, higher premiums, higher co-pays, higher co-insurance amounts. So your premiums are your monthly amounts that you pay to actually obtain health insurance coverage. Copays are typically amounts that you will have to pay, a flat amount that you will have to pay or a fixed amount you'll have to pay for each office visit you go to. Co-insurance is a percentage that you would have to pay for additional procedures and services after typically you meet a deductible. A deductible is the amount that you have to pay at the beginning of the year before your insurance starts paying and covering services. So typically, let's say, for example, if an insurance company has $1,000 deductible and after that they say they're going to pay 80% and then the patient's responsible for 20%. That 80-20 is that co-insurance amount. So in that particular example, you would have to pay $1,000 out of pocket for your deductible before the insurance starts paying that 80%. The point of service or POS types of plans is a tiered system. It's really a combination of your HMO and your PPO benefits. So for example, at work, I have a point of service plan myself. So with that point of service, I have a primary care physician that I have selected, and I typically use my HMO benefits because that's the least out of pocket that I would have to pay. So I go to my primary care physician. I usually have a copay for that visit. And if I need any referrals, they'll obtain the referrals from me or get prior authorizations if I need any kind of testing. However, I also have the flexibility. So that's HMO is a tier 1. I have the flexibility, though, also to use the tier 2 or the PPO network. And if I choose to use the PPO network, one, I will have to pay more out of pocket. Usually I'll have a deductible and the co-insurance, as well as potentially co-pays for office visits that I have. So I'll have, more to pay out of pocket. However, I will have a broader range of providers that I'll be able to see, and I won't need to get a referral from my primary care physician. I can choose who I want to go, and I can just call and schedule that appointment. So, along with that flexibility, there is that higher cost out of pocket. So just something to keep in mind and weigh. And then tier 3 is just your point of service. So the point of service, as it mentions, is a tier. Tier 1 is the HMO, tier 2 is the PPO, and then tier 3 is just in general considered the point of service plan. With your exclusive provider organization or your EPO, again, it's another combination of your HMO and PPO type plans. You may not need a PCP, and you may not need to get a referral with those EPO plans. Often you are required to see in-network providers, and those are the ones that you get the coverage from. And the cost of that EPO is usually higher than an HMO, but a little less than a PPO, which you would have to pay out of pocket, whether it's premiums or co-pays or deductibles and co-insurances. So, more prevalent are really your HMO, your PPO plans. EPOs are not so prevalent any longer. However, they do still have some plans out there that are exclusive provider organizations. So what you need to consider when you're selecting a plan, you want to look to see what type of plan. We've discussed the HMO, PPO, point of service, or EPO. You want to look at what your out-of-pocket costs are. As I mentioned, premiums are the amount that you have to pay to actually obtain health insurance. Deductible is the amount that you have to pay at the beginning of the year before your insurance company starts paying. Co-pays are usually a flat amount that you pay per office visit when you go to see your primary care or your specialist. And then that co-insurance is the amount, the percentage that you have to pay after you've met your deductible. You also want to consider how healthy are you, right? If you are healthier, you may, a HMO may be quite acceptable, because at that point, you have very few visits that you may need to go in. So, having a primary care physician gatekeeping your visits and obtaining prior authorizations or referrals may not be so tedious. If you are, need more services and you need more flexibility, you may want to consider a different plan other than an HMO. You may want to consider that PPO plan, because it does, again, gives you a broader network of providers to be able to see, as well as gives you a little bit more flexibility where you may not need to get a referral from a specialist to see a specialist from your primary care physician. So it just really depends on, how healthy you are, and you want to take those things into consideration. You also want to make sure that whatever providers you've typically seen are in network. So with an HMO, you have to see someone in network to have coverage. With PPOs, they have both in-network benefits as well as out-of-network benefits. With the out-of-network benefits, just keep in mind that you will be paying more out of your own pocket with that PPO type plan. So you want to make sure that you're considering, is that a PCP that you've seen forever, or that specialist that you really trust and that you've seen for years and years? Are they in that particular plan? Are they in network or are they out of network? And you really have to consider how much flexibility you really want to have, right? With the HMOs, it requires referrals to see the specialist, but it has lower out-of-pocket that you have to pay. Whereas with a PPO, it doesn't require those referrals to see the specialist, but it has a higher out-of-pocket, whether it's deductibles or co-pays or co-insurances. So the next few slides, these are just some examples of what we call summary of benefits and coverage for different types of plans. So insurance companies have to provide this type of insurance, this type of information to the patients who are considering obtaining coverage. So this particular example here, in the top right, you see it says point of service, POS. So this summary of benefits describes what is covered with this particular point of service plan. So this point of service plan is through Health Plan of Nevada. So here are some of the important questions you want, right? Is there a deductible? So with this particular plan, individually, a patient would have to pay $2,000 out of pocket for a deductible, and that's per member. Now, if there's family coverage, they would have to meet $4,000 out of pocket for their deductible. Are the services covered before you meet your deductible? There are services. It's typically preventative services that are covered before the deductible. And typically when you go in for a preventative service, usually that first one service, there's typically no deductible, no co-insurance that's associated with that particular service. Because again, HMOs really do want you to have those preventative and wellness visits to make sure that you aren't admitted to the hospital or have those emergency room stays.
Let me interrupt for just a second, if I may. The reason also that preventive care is covered is because when Obamacare went through, it was a requirement of the statute that preventive care be covered without cost to the patient. So besides the fact that your insurance company loves you and cares about you, it's also the law of the land. Thank you.
Thank you, Dr. Schultz. Another important question here, it says, what is the out-of-pocket limit for this plan? So the out-of-pocket limit is the maximum amount that a patient has to pay out of pocket before the insurance company will start paying at 100%. So I gave that example earlier of a $1,000 deductible with co-insurance of 80/20. And then once that patient has met an out-of-pocket maximum with that 20%, then the insurance company starts paying 100%. So for this particular plan, the out-of-pocket maximum that a member has to pay is $6,850 for that individual member before the insurance company starts paying at 100%. Now, if it was a family coverage, they'd have to pay $13,700 out of pocket before the insurance starts paying at 100%. Here, it gives you some different information as well, right? If you have a visit with your healthcare provider in the office or in the clinic, under the HMO plan here, it says that a primary care visit is $15. The deductible doesn't apply for just that office visit. Now that's under the HMO. Here, under your PPO benefit, it says that going to your primary care doctor, you will have a patient responsibility of 30%. So after you've met your deductible, you're going to then be paying 30% out of pocket. The insurance will pay 70% until that out-of-pocket maximum is met, where then the insurance will cover it at 100%. That's under your PPO. Now, under this plan, if you went and saw somebody out of network for that primary care visit, you would have to pay 50% out of pocket. So you'd meet your deductible, pay 50% until your out-of-pocket is met, out-of-pocket maximum is met, and that's in your out-of-network benefit area. Now, if you have to go to a specialist, which is the second row here, you pay $30 for a specialist office visit, copay. Deductible doesn't apply. If you see the specialist under your PPO plan and PPO network, you pay again 30%. And if you go and see somebody out of network, then you'd have to pay 50%. With preventative care and screenings, there's no charge for that. As I mentioned, there's typically no copay, no deductible, no co-insurance associated with preventative care and screenings. It then goes into diagnostic testing and imaging. So here it lists how much you'd have to pay, whether if you go in the HMO network, in the PPO network of that point of service. Remember, that point of service is a tiered plan where it has both HMO benefits as well as PPO benefits that patients can choose from. And they also have some out-of-network benefits, as you can see. So you can look through this and determine, okay, if you go in for a chest x-ray or some type of x-ray, you typically will pay $20 per x-ray when you go in. And that's with your HMO in-network provider. If you go to your PPO in-network provider, you pay 30%, and then out-of-network is 50%. And that's the same thing for CT scans and PET scans and other types of imaging. Here you have a $100 copay for in-network in your HMO, and then 30% for PPO and 50% for out-of-network. And then this is just a similar example for your prescription coverage. You have multiple tiers here. It tells you how much you have to pay per prescription for your copay. For your HMO, it's $10. And if you're in plan for your PPO under the tier 1, it's also $10. But out-of-network providers, if you go to, they will not cover under any of the tiers. So it's important to also always look to see how much you would have to pay for your prescription coverage and kind of calculate that into what you're looking at. This is just a different example of a HMO, and this is the Anthem Silver HMO 55. It gives you the list of different coverages that you have, right? Deductible, out-of-pocket maximum, co-insurance. So for the HMO 55, with your deductible, there are no deductible dollars under the HMO. However, if you go into this other plan here, it's $2,250 for your individual deductible and $4,500 for a family deductible. This then lists your out-of-pocket maximums. Your office visit copay is $55 to see your primary care physician, and that's why they call it HMO 55. And then it lists additional services: urgent care, emergency room, hospital inpatient stays. So you can see the differences here using this particular HMO service and plan. Below here talks about the different tiers for your prescription drug coverage, and tells you if you're using a retail pharmacy under the HMO plan, under the level 1, you have a $20 copay. Under the level 2, you have a $25 copay. That is the same with this other plan that they have offered. And typically, if you're looking across up through your level 3 and even into your level 4 area, it has the same type of prescription drug coverage. And we just have a couple of examples of insurance cards. Now, these are insurance cards that are sample cards that the insurance companies provide online. Some of the things that you just want to look at here, this is your health plan in Nevada. It tells you it's a group point of service plan, which means this is through an employer group. It's a point of service plan, which is at 3 tiers. The HMO is tier 1, PPO is tier 2, and then point of service is tier 3. This is your member ID number, which is typically when you call in and you're scheduling an appointment with the provider, and this is your first time that you're going in, the first thing they'll ask you is, what type of insurance do you have and what's your member ID number? They'll use that information to verify your benefits and eligibility to make sure that they can see you, that they do take that insurance, and that you actually are eligible and current with your insurance. So that's information that you'll always want to know on your insurance card whenever you're calling into a provider. This will be where your name is under the member name. The effective date, this particular card says it's 1/1/2017. And this is where you can look to see what the different copays are that you'll be expected to pay. So typically what you have is here your tier 1, which is your HMO tier. And usually what you'll see is when you go in, this first dollar amount, even though it's a zero, everything is a $0. So I'll explain a little bit. So this is your tier 1 HMO. The office visit copay for a PCP visit under your HMO plan is, let's say, $10. And typically your specialist office visit copay under the HMO will be more than that. So that it might be a $35 copay to go and see your specialist. Under tier 2, which is your PPO benefit, to go and see a primary care under your PPO plan and the PPO network, you may be paying $25 for that PCP visit under the PPO plan, whereas under the HMO, you would have paid $10. And to see a specialist, instead of that $25 for the HMO specialist visit, you may be paying $45 or $50 under the PPO tier 2 plan. So just different information that you want to make sure that you're aware of. And then the other thing that's important is the back of the card. We'll give you some helpful phone numbers for you to call in case that you need some assistance from the insurance. So your member service ID, phone number, as well as the 24-hour nurse line. And then if there are mental health and substance abuse concerns or questions, that there is also that information on that back of this particular card. And just a couple of other examples very quickly. So with LA Care covered, one of the things that you always want to make sure of, especially on an HMO plan, we have your name and your member ID number, which is also important. And it'll also list the copay amounts that you have to pay under copay or PCP visit. But the other thing that you always want to make sure is if you are in an HMO plan, that you see your PCP that is assigned. And sometimes the insurance cards will list exactly who your PCP or your PCP medical group is that you have to see. So this is where it's very important under the HMO plans that you know exactly who is in network and who your primary care, who you are assigned to as your primary care physician, because you want to make sure that you're seeing that particular physician and getting the referrals from that particular, if it's the group or that particular PCP. So very important to be aware of that information. And here again with your Aetna plan, it lists your member ID number. Here it has 5 different family members that are listed. So the first one, 01, Jonathan, is the insured, is the person who is working maybe and has this coverage. Everyone else is a family member. It might be a spouse and the rest might be children. And then it lists who the primary care group or physician is associated to that patient. And all of these 5 could be different PCPs. It just depends on what that patient selected when they registered and when they selected their primary care. Again, it could all be different providers. It could be 3 different pediatricians for the 3 kids. It could be 2 different primary care providers for the insured and the spouse. And again, important numbers on the back, member ID number and providers if they have to call. If you have questions about your prescription coverage, important numbers in the back of the card for patients to be aware of. And I'll end with talking about narrow networks. So narrow networks, typically health plans and employers are really starting to look at narrow networks, which gives you a limited choice of providers, even more so than your HMO plans. But in exchange, you do look at lower premiums. So there are, with narrow networks, smaller pools of providers. So there'll be smaller PCP pools, smaller lists of specialists in hospitals and diagnostic centers and other types of treatment centers that are available to patients. So again, very important to know exactly what type of plan you're selecting. In these narrow networks, providers have agreed to accept lower reimbursement for services because they expect to have more patients to see. So they're counting on having more patients, even though there's a lower reimbursement, because this does help to keep down the premiums that the consumers have to pay, that you as a patient would have to pay. And as I mentioned, with narrow networks, you really want to make sure you know exactly who is on that list of network providers, because in narrow networks, it could be even a smaller list of providers that you would be able to see, even smaller than your HMO plans. You can check to see on that insurance company's website. There's a lookup tool that you can look to see who those in-network providers are. And you want to make sure that, that provider is actually seeing patients from that narrow network insurance. You want to be able to give that provider a call to make sure that they're still accepting that plan, because sometimes the directories that are online are out of date. So you want to make sure that you're seeing somebody you're selecting somebody, or you're selecting a plan that has the provider that you want to see. Some other things that you want to consider when you're looking at a narrow network is, how far do you have to drive to see an in-network provider? So if that in-network provider or hospital isn't close to where you're living, are you willing and able to actually drive that long distance? Does it make sense to do that? Are there other things that you have to consider? Is there, childcare, elder care, the cost of gas, the time, your cost in time that it actually takes to get there? You want to consider all of this when you're selecting your plan, because in particular with narrow networks, you don't have much of a choice. So you may live in one county and your primary care physician that's within that narrow network may be an hour or two away. So you have to consider a 2 to 4 hour round trip visit to your primary care physician. And are you able to do that? Does that make sense for you to be able to do that? And you also have to look to see if there are actually out-of-network benefits with narrow network plans. Sometimes there are, sometimes there aren't. And sometimes you may have, a larger amount out of pocket that you have to pay looking at those narrow networks. So you really want to consider your financial responsibility and what that's going to be. And you want to compare the cost, actual cost, as in with your premiums and deductibles and copays and co-insurances, and that indiscernible cost, right? Your travel time, the gas, the stress of travel, and depending on how long it's going to take. And you also want to know, are there out-of-pocket maximums? Because if there are out-of-pocket maximums, you then at that point will know exactly what you have to pay every year, right? Because there is that maximum amount that you pay before the insurance starts paying at 100%. But if there is no out-of-pocket maximum, that means that there is really no limit to how much you pay out of pocket. So those are all things that you want to look at and consider from a financial perspective, right? You want to calculate those costs, both tangible and intangible, before you really end up selecting that plan. These are just some definitions that we've touched base on. And Dr. Schultz, I think that I have finished my portion. I'm going to hand it over to you.
Okay, well, thank you. I was going to ask you if you could keep managing the slides for me.
Happy to.
And I will blather. Okay. So this is a little mock-up. This is not quite the yellow brick road, but these are very, very valuable bricks. And I am going to be talking about following the money in some detail. Shireen was very objective. I tend to be a little more opinionated, but this is going to be more of a ground level view as opposed to the 30,000 foot high view. Next slide. So PPOs are pretty simple. You have a premium that gets paid by somebody. You have an understood amount that you get to pay your providers, whether they're physicians, primary care specialists, x-ray folk, whatever they are. And the insurance company essentially sets the rates for that. You will pay whatever it is you're supposed to pay. You go where you are supposed to go. You learn the rules and you're done. And at that point, the insurance company remains the insurance company. That's a preferred provider because the insurance company is indeed managing the risk. With HMOs, on the other hand, the insurance company collects the money, but then it is very, very entertaining to see where the money goes. So this mock-up is from Healthcare Policy Issues, written by our professor, Paul Feldstein. Don't worry too much about the numbers because they will change. But what an HMO will do is they typically will collect the money. They will then take anywhere from 13 to 20% for their quote administrative costs. 5 to 10% will be for profit for the shareholders, more if they can get it. They will then keep money by contract set aside, typically to pay hospitals. That will be the hospital pool. The approximate number for that is usually 40 to 45%. This all depends on contracting. They will contract with hospitals to accept whatever rate it is they negotiate for whatever services they negotiate on behalf of the clients. Typically, the insurance company will keep that money in their hot little hands and invest it wherever they invest money. There is another pot of money that they will use to pay physicians, and the physicians could be employees of a staff model. Kaiser would be a staff model. They are all employees. Mayo Clinic similarly. They could be an independent practice association, which are groups of doctors without walls that have banded together to essentially contract with HMOs. They could actually be physician groups. However that is, usually the number that I've seen more typically is 20 to 30% goes for physicians. Depending on how the contract is written, the physicians group may also be responsible for paying for any of the patients who wind up in nursing homes, for outpatient surgery, for durable medical equipment such as canes, walkers, you name it. And then typically the insurer will have a pot of money for pharmacy benefits. Typically that gets rolled into also eyeglasses and hearing aids. If in fact the insurance company manages to not pay out to the hospital what they expected to pay, or what the physicians would have cost them from a variety of actuarial standards, there is then some money left over. Some of that is kept by the insurance company, but depending on contracts, the hospital may have a residual where if costs were less, they get a percentage of the leftover money. The same is true of the physician group, which can then use the excess money to dole out for their physicians. There obviously are incentives for both the hospital and the physicians built into this model to keep costs down. And we'll get to pharmacy in a bit. Next slide. So the way the money flows to the hospital, this is a negotiation. You will see the insurer will contract with hospitals. They will pay them either on a per diem basis. So say one of their clients gets admitted to hospital, they may pay them, say, $300 a day, or they may pay them by the diagnosis, the way Medicare pays, or any variation upon the same. Typically, they are holding the money in the risk pool. And the insurer will want, obviously, decreased hospitalization, which really is a goal pretty much of all of us. This may explain, however, why patients come flying out of hospitals in less and less time. Next slide. So how do physicians get paid? In urban areas, most likely the insurer will want to contract with a physician group, which is organized in whatever way the physicians choose to organize. Why? Well, the insurer would much rather negotiate one contract than 1,000 contracts. And that is why the physicians typically band together to have negotiating power. They are typically paid a fixed amount per member per month. Typically, it's some percentage of premium. And now what the insurance company has done is make the physician group the insurance company, because they have paid their amount. They are no longer at risk, which is the definition of an insurance company. And the physicians will now have to manage typically the primary care payments, the specialty payments, the lab imaging testing services. They are expected to monitor for quality. They have their own administrative expenses doing this. And depending on the contract, they pay for other things. If you are a patient, you need to understand that these physician groups may not overlap. So you will want to make sure that your selected plan which may require you to select a physician group, includes the physicians, specialists, labs, and other facilities and hospitals that you want to go to. And typically, as Shireen pointed out, the physician group's name will be on the card if that is how the contract is done. Next. So now what happens is that if the medical group can somehow cut costs so that it has not exhausted its pool of money, it then has some money and it may be able to get some incentive payments for reducing costs. Why do physicians do this? Because in some areas, there are not a lot of independent patients to be had, and the groups control the flow. Understand that if you are 35 years old and generally speaking have an HMO plan, your primary care physician may be getting about $9 to $13 per month to take care of everything you need. You might understand from that that sometimes physicians are not too enamored of your calling them and seeing them every week for your $10 a month. However, it is true that during COVID, when physicians' offices really were closed and not seeing patients in person, there at least was some kind of revenue coming in. On the other hand, if you are a physician and you have too many very sick patients, it costs you financially to see these patients. Next slide. Forgetting the very busy stuff on the slide, concentrate on the red man. The red man, many of the insurance companies will engage a pharmacy benefit manager. So they contract with this pharmacy benefit manager to manage drug costs. The pharmacy benefit manager now negotiates with pharmacies and pharmaceutical manufacturers to buy things at reduced costs, whatever the pharmaceuticals are they choose. They will often arrange rebates from manufacturers. They have very sticky fingers. So these are for-profit companies that are essentially another layer between the consumer, the employer, and the benefit. Next slide. Typically, there's a pool of money set aside. The insurance company may elect to keep that money. By law, Part D drug plans, which was the George W. Bush Medicare prescription coverage, must be sold and administered by private companies. This was obviously a win for private insurers. Understand that Medicare Part C, also called Medicare Advantage, by definition is an HMO plan. It is no longer regular Medicare. The last remaining non-managed care major insurance in the United States turns out to be Medicare. So these pharmacy benefits managers make money by a variety of financial arrangements that were so obtuse that even the insurance company has lost patience with them, and some of them decided the heck with that, and they decided to buy the pharmacy benefits managers. For example, Humana has their own pharmacy solutions. Cigna bought Express Scripts. United owns OptumRx, and then a wonderful turnabout being Fair Play. CVS, the pharmaceutical chain, which also has a pharmacy benefit company called Caremark, they went out and bought the insurance company. They bought Aetna. They are big enough and powerful enough that they actually own Aetna. Interesting. Next. What does this mean if you actually need to get a prescription? Obviously, the drug tiers will want you to be moved toward the lower priced medications. Understand that sometimes you may pay less for a prescription just by paying cash. So if you have a tier 1 drug, a generic drug, typically they're inexpensive medications. They may cost $5 for 30 retail at a place like Walmart or Target or thereabouts. But your copay might actually be $25 for the same prescription. There are times when it turns out it is cheaper to go and buy the prescription retail than to go through your insurance. However, if you are looking at a plan, you need to review your medications early and often, because if you require a life-sustaining medication, and this is now going to cost you some very huge amount of money because your insurer will now move this into a very expensive tier, that is a cost that you need to actually put into the equation when you're looking at insurances. The expensive medications will often require a prior authorization, which means your primary care physician is expected to submit to the pharmacy benefits manager a justification for your taking that pharmaceutical. This means you will wait for that authorization. Sometimes the doctor is required to have you, they will say, well, have you actually tried drug A and B? And then once you have tried and failed that, the patient is the guinea pig, you might be able to get drug C. And they will want dates and amounts next. So you can see that in this rather interesting financial system, there are negotiations going on at every step of the way. The employers want to cut their costs. The employees would like to pay less. The insurers, of course, would like to have them pay more. The shareholders of the insurance companies want more profits, and therefore they want more of the dollar sent to them and less spent on medical care. The hospitals want more money. They have banded together, many of them. You'll see hospital chains. You'll see big hospitals buying littler hospitals so that they essentially have monopoly power. Sutter in Northern California is basically the dominant hospital, and they can negotiate. They will go toe-to-toe with the insurers every year to try to extract more money. Physicians want more money. The insurer would rather pay them less. So at all of these steps, you will see that we have full employment for actuaries, attorneys, contract negotiators, overseers, and this goes on and on. So there are all these financial, I would call them inefficiencies in the system. Next. To give you an idea of what, quote, administrative and overhead costs are, employers typically pay for employee healthcare premiums, those that do cover their employees. Typically, these run 8 to 12% of payroll, but it can be more. Understand that if you are an employee and your employer is paying $5 an hour on your behalf for your healthcare insurance, that is $5 that you are not collecting in wages. So yes, it is a benefit, and yes, it is a cost to the employer, but you are not taking that home with you. The typical administrative cost for Medicare is 2% in the United States. That's also what it costs in Canada, by the way. For the commercial insurers, the Humanas, the Aetnas, the United Healthcares, the Blue Crosses, the Blue Shields, the Anthems, their administrative costs, as they define administrative costs, will be 13 to 25% of the dollar. If they then contract with a physician group, that physician group has administrative costs because they are then doing prior authorizations, physician oversight, and that's another 10% off the dollar. I cannot begin to tell you how and what hospitals have for administrative costs, nor pharmacy benefit managers. I can tell you, however, that when I started practice, our overhead was about 40%. With managed care, our overhead climbed somewhere between 65 and 70%. That means your primary care physician may be working through September before they take home a nickel on paper. Next. So your job as an informed patient is, number one, if you are going to have an HMO or even a PPO, your job is to select a primary care physician. This is from the Hill Physicians Medical Group website. They are a medical group that contracts with insurers on behalf of their member physicians. And this is the job description for primary care physician, your go-to doctor for everything. Annual physicals, sickness exams, sickness care, answering your questions, referring you to the proper specialist, managing your chronic diseases, diabetes, high blood pressure, whatever, coordinating your care, and also being your gatekeeper. That means that your primary care physician, even though they want to be your friend and give you everything, is not able to do that. They have to discriminate between what you need and what you want. They are not always the same. It is their job, based on something called professional ethics and morals, to make sure that you get what you need. What you want may be more than what you need, and therefore they may have the unenviable job of telling you, I don't think you need that expensive imaging test or to see that super duper specialist because we think we can handle that in-house. Yelling at them is not a productive exercise. We'll go into what may be. Next. This is meant to show you, it's not showing up very well, the supply of primary care physicians in the United States compared to other countries is very low. It's actually about 0.3 doctors per 1,000. In other countries, it tends to be somewhere between 0.8 and 1 per 1,000. The reason for that, and the ratios in other countries tend to be about 2 primary care physicians for every specialist. In the United States, it tends to be 1 primary care physician for every 3 specialists. Why? Because specialists in the United States have traditionally gotten more respect and more money. Ergo, doctors are incentivized to specialize. I have heard from many patients and patient advocates, it has been very difficult to find a primary care physician. That is true, and this is in part why. Next. There you go. So there are actually the numbers. We are at the bottom of the heap. It really doesn't pan whether you have socialized medicine in the UK, national health insurance, single payer as in Canada, or private insurance companies with highly regulated systems such as Germany or France. The US is short on primary care physicians. This has been predicted. It is coming to pass. Next. Job 2, if you require specialty care for whatever condition, you have a malignancy, you have a heart condition, you have a complicated arthritis condition, you want to make sure that your specialists are in whatever network you choose. And if you must choose a medical group, make sure that medical group has all of the doctors that you think you will need. And you need to make sure that if you take medications that are expensive by list price, you need to factor that into your equation, because just that prescription alone, there are $1,000 a month prescriptions, $30,000 a year prescriptions. The new Alzheimer's drug that was approved is a $56,000 a year prescription. So That is a cost that you need to evaluate as part of the equation. It's not just about the premiums, the copays, and the deductibles. Next. HMO job 3, compare the plans that you may be offered. If you're planning on having a baby, make sure that somewhere along the line, maternity is included. They don't always. If you work part-time out of the area, make sure that you can get health care when you are out of town. If you have mental health issues or HIV or diabetes or other special circumstances, you need to make sure that somehow or other you can get that care. And finally, add up all of your anticipated expenses, and then you decide what it is that you want to pay, can afford to pay, think you will need, and whether or not you need to make sacrifices one way or the other. Next. So I put down a Kaiser Permanente sample because Kaiser is actually one of the more transparent carriers. This is the individual market. So this is actually the Obamacare individual market that is set up to have bronze, silver, gold, and platinum plans. So for those of us who are forensic accountants, you can look at this and see the various plans compared. These have $6,000 deductibles to $8,000 deductibles, even though these are HMO plans. So an HMO does not always mean a lower deductible. Next. This is basically something that looks like a Sears catalog where they have good, better, and best. So the basic option has a higher deductible. So that would be good, better is the standard, and high option has no deductible. And then you can compare all of these services in tables. There is a trade-off between the amount paid in premiums and the amount that you will pay if you need to access these services. Next. Job number 4, even though your chosen physicians are in the book, you would be well advised to make sure that they will accept whatever plan it is you elect. Should you change your healthcare team, which is not recommended unless you are most unhappy with what you have, make sure that they will take new patients. Many practices are not. Make sure when you get that nice card that Shireen showed you that the information is accurate and that the person that you hope is your primary care physician is on that card, and that the medical group that you have selected is also on that card. If you are in open enrollment, don't wait until December 31st to make your choice. You want to make sure to check the pharmacy formularies. These are changed every single year. One last caveat, if you understand or read in the news that say your local hospital has not yet agreed to a contract with your insurer, don't panic. They often don't. Typically, Sutter and one of the Blues will have a knockdown, drag-out battle that they will settle at the last minute. Don't worry. Typically, they will make an agreement because neither one is powerful enough to ditch the other in general. Next. Now, what does your doctor think of all this? I would be remiss if I didn't talk from the point of view of a doctor. This is the president-elect of the American Academy of Family Physicians, who says, what a bureaucratic mess. Next. So there are obstacles to getting what you want and what the doctor thinks you need. So this is the barrier. You either go over it, through it, or under it, or around it. Prior authorizations are a major pain in the neck for physicians, that means that somebody has to fill out the forms and submit this and then wait and then notify you that whatever it is authorized. The specialists in the plan may not be the people that I think are best as a physician, but that is what there is. The medications available or the treatments available may not be what we would think are optimal. You as patients need to understand that your plan has made these choices, your physician has not. Our administrative costs are higher, and frankly, it may be that we should really fight for prescriptions for 20 to 30 patients a day or authorizations, but we really don't have the time to do that. So if you consider the post office, most of the mail gets delivered at some point in time. If you want special delivery, there's extra work involved for everybody, and you may not have a special delivery kind of need. Physicians really do not like feeling that some third-grade dropout is watching over them, making decisions. The pharmaceuticals are typically rejected by computer or a pharmacy technician, not even a pharmacist. The prior authorizations are usually handled by a computer, and then they may be bucked up to a nurse. And finally, the scorecards are done because there are certain things that are easy to measure, not necessarily what makes the biggest difference in your health. These are all under the rubric of hassles, and that is why you will see physicians in their late 50s and 60s retiring. Next. This is an example of how much time is spent in hours per week, not only by physicians, but by the nursing staff and by the clerical staff. So we were looking at 53 hours per week of the physician staff time spent dealing with payers. Much of this is spent on the phone trying to get through. Often it is spent submitting the forms and then submitting the appeals of the forms back and forth. Understand that while the insurer may be saving money at the ground level, hospitals, radiology centers, surgery centers, and physicians' offices are absorbing that cost. So there is an argument as to how efficient and money-saving these managed care plans really are. Next. And this is a cost. This tells you, the references on the bottom, that an average US physician, and this is 2011, so it's more now, spent an extra $60,000 a year compared to their confreres in Canada, which only has one insurer dealing with insurance companies. That is a cost. This is often in terms of payroll. This is good because there are more people working. The question whether this is productive or not and benefits your health is another question. Next. The doctors are scored on costs. So in fact, if you look at this chart, this is a real chart from a real doctor. You will see HCC is actually how much complicated coding you can do to make your patients look sicker so that you get better reimbursement, because some of the reimbursement is based on having more sick patients. You are rated by having generic prescriptions as opposed to trademark prescriptions. The big ones are actually inpatient days, which are scored. More inpatient days, as you know from previous discussion today, means more cost to the insurance company. They don't like that. You are considered a bad actor if your inpatient days are higher than goal. In addition, emergency room visits and inpatient admissions, and these are all scored. So your doctor, I'm familiar with a patient in North Dakota who had COVID and was ill. He was sent to an outpatient infusion center as opposed to a hospital emergency room. There was a reason why. Next. So final thoughts, and I will end here. Know your priorities. What is important to you? Know the alphabet soup. Know how much you wish to prioritize choice versus cost. Use those comparison tables, even though they are not always meaningful. Understand that saving money, that what looks like saving money is not always saving money. We had a patient who was persuaded to change a prescription plan to save $10 a month, but discovered that her $500 medication was not covered by the new plan. Surprise, you'd better be careful. In general, the individual market is a problem because these are not very good plans that are available. They have high deductibles and limited choice. If you can join a group, whether it be a union, an employer group, a professional group, negotiating as a group tends to be better. If you can use other people's money, such as an employer, use it. Don't ignore pharmacy costs, and in general, understand that changing your healthcare team is not recommended because the new team needs to get to know you. They need to get records. They need to review records. They may not know all of the nuances of your situation. And in order to get what you want, you must be the squeaky wheel. If you are not the squeaky wheel and you are one of the nice, meek 500 or 800 patients somewhere floating out there, you may not get not only what you want, but what you need and what you deserve. So don't be afraid to speak up, but abusing the people that you have to deal with is not productive. You need to give reasons for your requests. And it may well be that you may not have this in your records, but I tried such and such a medication before, and this is what it did to me. So that is data that can then be resubmitted to get an exception. Or I have new symptoms, so that waiting 6 weeks is really not an option for me because I'm now having debilitating pain. Next. Hello, Shireen. Next. Okay. Next month, we are going to switch gears again. My colleague, Susan Bucker, who's our mental health person, will be talking about patient advocacy and mental health via Zoom. We'll be back to Tuesdays. That'll be October 26th at 6:30 p.m. And let's unmute ourselves and